Can I start, sir?
Yeah. Told you. And start.
Good evening, everyone. Today will be the continuation class of the part 2 of peripheral vascular disease. Today we will be dealing about the investigations and the management. So before we start, let's brush up whatever we have done in the previous class. So I'd like to ask a couple of questions to the students there. So Samir, can you tell me the difference between a dry gangrene and a wet gangrene? Samir, are you there? All right. Vinod, can you tell me the difference between them?
No?
Dry gangrene and wet gangrene?
Yes, ma'am. Dry gangrene is basically because of arterial blood supply compromises, and that will lead to death of the tissue, and which leads to gangrene of the tissue. And there is a clear line of demarcation. When this is super added with the infection, it leads to wet gangrene, and there won't be
Yes.
any clear line of demarcation.
Yes. And Praveen, can you tell me what criteria we used for Burgess disease? And what is the other criteria that Shravan sir asked us to find out?
Shinoya criteria and Wolin's criteria.
Yes. Can you enumerate the components of Bolen's criteria, Vinod?
Yes, ma'am. If they compared to Shinoya criteria, age will be lesser, which is in Shinoya it is 50 years. Here it is 45 years.
Yes,
And
good.
and in Shinoya they will use smoking history. It will be divided into acute and something like chronic history and acute history. In
Yes.
Wolin's, it will be something like whether the patient has smoking history or not, and they
Ah,
will rule out this ischemia changes, something like ulcers, gangrene. These are all present, and other atherosclerotic changes. Causes for the atherosclerosis should be ruled, should not be present in the patient except smoking.
yeah. And also in Bolen's criteria, you need
We
to
have,
exclude autoimmune disease,
yes,
hypercoagulable state also.
yes, ma'am. That is there in both, I think, ma'am.
Yeah. And what about the peripheral pulses? I think it has been told, but you guys have to put up in the group about palpating the peripheral pulses. So if
Yes.
you guys have any doubts regarding the previous class, at the end of this class, you can ask me. Now let's move on quickly to the investigations. So when we talk about investigations, there are some invasive investigation and non-invasive. Moving on to the non-invasive one, and which is most commonly done for a peripheral arterial disease is a duplex scan. So duplex scan is nothing but your grayscale ultrasound plus Doppler. So what happens is here you because of the ultrasound image, you get an anatomical view, and also the Doppler gives you the physiological and hemodynamic data. So you can find out where exactly is the arterial location, arterial occlusion here, and also it helps in deciding the therapeutic option. So before moving on to the waveforms, let's understand what exactly this Doppler principle is. So your Doppler probe will have a piezoelectric crystal, and this piezoelectric crystal will give you the Doppler signal. This Doppler signal will hit your skin, then it will go to the vessel, and the vessel, as we all know, has RBCs. So what happens is when these signals will hit the vessel, because of the movement of the moving column of the blood and the RBCs, what happens is there is a frequency shift, and then this shift is reflected back, and then it is received by another piezoelectric crystal in the Doppler probe. And this frequency shift that is happening, that will be measured, and you get a waveform. So I guess you guys understood what it is. So now moving on to the waveform, let us see how a normal Doppler waveform happens. So normally what happens is you see a sharp peak up during the systolic phase, and also there is a diastole. In the early diastole, you see there is a zero crossing there. Can you see here? There's a zero crossing here. And also this zero crossing happens because of this elasticity. And this small zero crossing, after which you have another phase where it is because of the rebound. So this is a normal arterial waveform, which means the flow is good to that particular area. Now, what happens is when there is a stenosis, the first thing that gets hampered because of a stenosis is this zero crossing, because the elasticity of the vessel is gone because of occlusion. So what happens is you have this there is no a negative waveform here. So you have this is called a biphasic waveform. So the normal one is the triphasic waveform and the abnormal one is biphasic. And when the stenosis increases in severity, what happens is this systolic peak also becomes smaller and it also becomes wider, and this diastolic is completely abolished. So you get something like a monophasic waveform. So these are the important thing that you should know in case of Doppler. And also what happens is, one interesting thing is in your internal carotid artery, what happens is you don't see this zero crossing. Can anyone tell me why it happens? Okay, I will tell you, because see, internal carotid artery supplies your brain. At any point of time, there shouldn't be any absence of flow of blood there. So there is always this Doppler waves will be in complete. There is no, what do you say, the zero crossing or relaxation phase. That is why in internal carotid artery you don't get this triphasic wave, but everywhere else in a normal flow you get a triphasic pattern. And next would be the CT. So why do we have a CT angiogram when you have something like a non-invasive form of Doppler? The thing with Doppler is, if you have to see for aorta-iliac vessels, then because of the abdominal obesity and because of the presence of aorta in the retroperitoneum, it is very difficult to penetrate that area. So in those kind of cases, CT angiogram will give you a better idea. And also there are places like internal thoracic artery where you can't literally put your probe on, better to have a CT angiogram. So CT angiogram, here again, what you do is you inject a dye through your IV line, and then this dye will trace the entire vasculature that needs to be traced, and then you get the cut sections. One thing is, this CT angio, we can have a 3D reconstruction also, which is possible because of this CT angio. But what you need to do is you need to get an RFT, because patients who have these peripheral vascular disease, these people will, some of them will have what you say, a concomitant renal dysfunction. So it's better to get an RFT, and also you need to hydrate the patient before and after getting the CT angiogram. And some of them, what happens is they will be taking metformin. So in Bailey, there is an interesting point that is given that there is certain reaction with contrast and metformin that can cause metabolic injury. So these things you need to take care of. And when you talk about the advantage of the CT scan, it's easy to do, and you can plan your intervention based on the vascular imaging that you get it. And also you can have 3D reconstruction, wherein in the disadvantages, it is obviously an ionizing radiation and you're using a contrast. So this contrast itself can cause some allergic reaction, and also this contrast can cause some metabolic reactions. Suppose if the patient is on certain pharmaceutical drugs. So these things you need to keep in mind. Another thing is, when you talk about a diabetic patient, so diabetic patients will have calcifications. In diabetic patients, suppose you're suspecting PVD, which one you would prefer, a CT angiogram or anything else? Samir?
Is Samir there or is he gone? Is he taken off holiday?
Sir, MR angiogram, ma'am.
Okay, why?
He's there.
MR
Why?
angiogram with time of flight view.
Okay, why?
Because we can't give contrast.
Mhm.
The MR with time of flight we can do fairly good. This thing.
Okay. See, what happens is, like I told in the last class, in diabetic patient, there will be vessel wall calcification. So in a calcified vessel, MR is a better option compared to CT. It can delineate between the calcified vessel and also the contrast. And okay, now I hope it is clear till this. Let's move to digital subtraction angiography.
Yeah,
So
I'll just add a couple of things, Dr. Nithya.
yes, sir.
Yeah. So in Doppler, one advantage, like you said, is the physiology. But second thing, you can also see the presence of the type of the occlusion, whether it is acute or completely chronic or acute on chronic like that,
Okay.
which very difficult to differentiate in a CT or MRI. That is one advantage if the Doppler is done properly. First thing.
Okay, sir.
Second thing, in CT, like you said, in diabetics, you have highly calcified vessels, and the imaging in a highly calcified vessel, you may not be able to differentiate, especially in the tibial arteries, whether the flow is seen or whether calcium is seen. The software will not be able to differentiate, and even when we try to change the contrast, you'll not be able to differentiate whether it's an open segment or it's a closed segment. Okay.
Okay, sir.
So,
Yes, sir.
and another advantage of CT is, like you said, iliac disease is very much clearly seen in CT rather than
Yes.
MRI.
Okay, sir.
So you have a lot of patients with concomitant aneurysm. They may have,
Yes.
they may come with critical ischemia. You may be working up for a peripheral arterial disease,
Mm.
but the choice of imaging for an aneurysm is a CT. So when you
Yes, sir.
have combined aneurysm with peripheral arterial disease, CT only should be done.
Okay, sir.
The ideal CT, vascular imaging CT, should have a slice thickness less than 1 millimeter.
Okay, sir.
Acquisition should be less than 1 millimeter thickness.
Okay, sir.
Okay.
Yes.
Second thing, more than the creatinine, what is more important is the GFR.
Okay.
Okay. So one person's GFR, 80-year-old with a creatinine of 1.4 and a 20-year-old with a 1.4 creatinine, their GFR will be entirely different.
Yes, sir.
Okay. So low GFR, it is ideal to go for an MRI. So
Okay, sir.
MRI, actually, if you see in reality, up to creatinine of 2, MRI can be done. But
Okay, sir.
if you see in centers where there's a florid vascular department, the radiology will be doing MRIs up to a creatinine of 2, nothing happens. The
Okay.
fact they tell that the patient will get nephrogenic systemic fibrosis, all that is a very, very, very rare thing.
Okay, sir.
Okay, so that is
Yes.
one thing. So the choice of imaging has to be clinical. So let's say you have a patient with gangrene, long-term diabetics, palpable femoral and popliteal, and you know clinically that the patient has only a tibial disease. Tibial disease, without doubt, the choice of imaging would be MRI.
Oh, MRI. Okay, sir.
Okay.
Yes.
Let's say you have a patient, you don't have a femoral pulse at all.
Yes, sir.
Okay. That time, a good choice is CT.
CT. Okay, sir.
Okay. Femoral artery
Yes.
doesn't matter. So iliac better seen in CT, tibial better seen in MRI.
Okay, sir.
And what Dr. Samir was talking about is MR angio TOF, which is time of flight sequence. Now, in a patient with raised creatinine, and where you cannot, let's say creatinine of 2.5 or something, where you cannot do a CT angio or an MR angio. In
Okay,
time
sir.
of flight sequence, without giving any contrast, they do a ECG gated MRI.
Okay,
Now,
sir.
the software detects the flow of the blood in the vessel and gives the images.
Okay,
Now,
sir.
to get a good TOF image, you need to have a good MRI machine, and more important, actually, a good MRI technician.
Okay. Okay, sir.
Okay. So,
Yes.
any patient with high creatinine, choice is MR TOF.
Okay,
Okay,
sir.
I think you can go ahead.
Yes, sir. So, next we'll talk about digital subtraction angiography. It is an invasive procedure. So what we do is we inject a radio opaque dye into the artery. Suppose you have to do a digital subtraction angiography of your femoral vessel. You inject it into the common femoral artery. And then this injection is, how you inject is by the Seldinger technique. Like once you put your guide wire and then you cannulate it and then you inject the dye. And then you serially start taking the images. And these images are digitalized into the computer system, and the background, that is the bones, soft tissues, and all the other things are subtracted. So technically, when you subtract the the vascular part of that sequence will be seen. And then another thing here is it is generally planned to do a DSA when you're combining with an interventional procedure. Say, for example, we are going to plan for a endovascular procedure to stent a particular region, suppose a tibial or a femoral artery. That is when first you do an angiogram and then see the entire the segment of occlusion, whether it is single segment or multi segment, because it will help us in planning the stenting as well. And then we combine it with a therapeutic procedure like endovascular procedure, PTA. And when we talk about the uh, complications of digital subtraction angiography, the same thing, since it's an invasive thing, you can have a bleeding and there can be thrombosis at the site of cannulation. There can be false aneurysm and dissection formation. And sometimes, very rarely, there can be an anaphylactic reaction to the radiopaque dye that we are injecting. Uh,
Nithya,
Sir?
this is what you're describing is arteriography.
Yes, sir.
Digital subtraction angiography, I thought you injected the dye into a vein and then get pictures.
Sir, in the textbook, it is given as in the artery, sir.
It's in the artery only, sir.
In the artery.
No, DSA is different from arteriography. Shravan?
Sir, arteriography is without a subscription. DSA, in arteriography, you can do a continuous segment, sir. So the cath lab technician will follow the flow of the contrast all the
Yeah.
way from the injection point towards the foot. But in
Yeah.
DSA, it will be a segmental, only that segment, like Dr. Nithya said, once we inject, the initial capture would be the soft tissues and the bone together. Then it will immediately, within a second, all that will become blank because it's digitally subtracted. Then the dye will go through. So you have to do a stepwise manner. The upper part of the femoral separately, then the lower part of the femoral separately, the popliteal separately, the tibial separately, like that. So an regular arteriography, it's a follow through. In digital
Yeah.
subtraction, it's a step by step.
Right. So, but generally, you do an arteriography when you're planning the intervention, right? Rather than
So
DSA.
nowadays we don't do any diagnostic arteriography, sir, because we
I
have
know
good
you
CT and
only
MRs.
plan. Yeah. You plan MR angiogram and then you plan the intervention.
Yes, sir. Yes, sir.
So the role of DSA is almost not existent at all.
Yes, sir. DSA for diagnosis is almost gone, sir.
Yeah.
Sir, can I continue?
Yeah.
So moving on to MR angiography, like we have already discussed, it is for a tibial disease where we can delineate the the calcification from the blood, actual blood vessel. And one more thing about MR angiography is that people who are having a pacemaker or any kind of metal in situ, for them it is a limitation. And another thing, I am really not sure, there are studies saying that it can overestimate the degree of stenosis. So I wanted to ask Shravan sir, is it really true?
That's true. That's true, especially in a highly calcified vessel. We have something called as a calcium blooming.
Okay, sir.
So that can cause an overestimation sometimes. Again, all that depends on how good your technician is.
Okay, sir.
Yeah.
And as sir said, if the GFR is less than 30 ml per minute, gadolinium contrast needs to be avoided, because the textbook says that gadolinium can cause a nephrogenic systemic sclerosis.
Fibrosis.
Yes, fibrosis, sir. And before we go into the treatment, I would want to talk about something called Wi-Fi classification. So why this classification has come, let me give a small insight into it. So what happens is, previously when there was Rutherford and Fontaine classification, these did not consider much about the diabetic patient. So in a patient who has diabetic foot ulcer, there will be some amount of ischemia or underlying peripheral arterial disease. So what happens is in these patients, we generally don't go in depth uh, in evaluating the ischemia or doing a Doppler. So what we do is we try to control the sugars, we keep doing dressing. So technically, when Rutherford and Fontaine classification was introduced, it did not consider importance to the diabetes, and also there are certain issues like it did not talk about the wound characteristics and also the severity of infection. So what this Society of Vascular Surgery has come up with is something called as Wi-Fi classification. So it is something analogous to your TNM thing. So it is basically a limb staging system. So what happens is Wi-Fi. So W stands for wound, I stands for ischemia, and FI stands for foot infection. So what happens is each of this wound, ischemia, and foot infection, there will be a grade from 0 to 3. Everything will be graded from 0 to 3. And then there will be a combination of 64 values. And finally, we will have a stage 1, 2, 3, and 4. So based on this, I would show you, I mean, you don't have to remember the entire Wi-Fi classification. It's given in Sebastian. But what you need to understand is that as there is written recent meta-analysis also that says that the likelihood of amputation at 1 year increases progressively with the stage of Wi-Fi. Suppose stage Wi-Fi 1 will have 0%, whereas stage Wi-Fi 2 will have 8% at end of 1 year, and Wi-Fi grade, I mean stage 3 will have 11% chance of amputation, and 4 will have 38%. So this is something new and very high chance of getting a short note question in this. And now we'll talk about the treatment. So here, when we talk about the
Dr. Nithya,
treatment, yes,
I'll
sir.
just, sorry to interrupt. There's one
Yes,
more classification which still is relevant, at least in the end surgical exams, is the task classification.
yes,
So the
task
task
and
should be mentioned. Most examiners know about the task. The
yes, sir.
Wi-Fi, if the examiner is interested about it, and because it's already introduced in Pakistan, so you'll be expected to know about it. But task
Yes,
is something you should know.
yes, sir.
Would you like to elaborate on that?
Yes, basically task classification is nothing but a transatlantic society of consensus. So basically what happens is they kind of divide the ioto-iliac disease into 4 grading, task A to task D. So where task A is basically a short segmental disease in the aorta-iliac bifurcation. And as we progress to task B, there will be a little bit more, the thrombus will be even at the bifurcation and also into the iliac vessel. So as we progress, it will involve, when we go to task D, there will be multiple segmental thrombus. So aorta also will have, and iliacs will have, and also the femoral and part of the external iliac and popliteal will also have thrombus. Sir,
Yeah.
I don't
So
remember
no,
verbatim.
there is no exactly.
Issue.
That is what I was about to come. Even we don't remember. We may be vascular surgeon, but even we don't remember it. I'll tell you why. Because
Yes,
a simple way to remember is it is an anatomical classification
yes,
based
sir.
on which segment is involved,
Yes,
one
sir.
or multiple vessels are involved, what is the length of the stenosis or occlusion, or
Yes,
if
sir.
any important vessel ostia is involved.
Okay, sir.
Okay, if you remember, that is enough. Now, why they did the A, B, C, D is task A lesions can be treated easily in an endovascular manner.
Yes, sir.
Task D lesions ideally require surgery if the
Yes,
patient conditions allow.
yes,
Task
sir.
B, you can do preferably by endovascular, but surgery is possible.
Yes, sir.
Task C, preferably surgery, but endovascular is possible. So that's how they split task into A, B, C, D.
Okay,
You
sir.
have a separate task for itoile, you have a separate task for femoropoptity, and you have a separate task for tibia.
Yes, sir.
Okay, so
Yes,
the problem of Rutherford and Fontaine was it took into consideration only the ischemic component.
yes, sir.
The task took care of only the anatomic component.
Mhm.
So in that's why Wi-Fi came, where you're looking into the ischemia, the wound, and the infection together. And without
Yes,
doubt, as of now, the best available classification is a Wi-Fi classification.
Yes, sir.
If at all you cross this level and your examiner is impressed, then the final question in terms of staging can be what is the latest available staging in for PAD. That would be glass staging, GLASS, glass.
Oh, glass staging.
Okay, so glass
Yes.
staging very recently introduced, less than 2 years. Still lot
Okay,
of
sir.
data is coming in whether how good it is, but
Yes, sir.
just remember the name glass staging.
Yes, sir.
Okay.
Okay, sir. So, moving on to the treatment part, one thing that we all need to understand is peripheral arterial disease does not just confine to the extremities. It obviously the disease is systemic, and there is a very high chance that this patient can have a myocardial infarction and also a cerebrovascular accident. So, what we need to do is you need to first of all decrease the cardiovascular morbidity and mortality, and then you need to improve the limb related symptoms. So for decreasing the cardiovascular morbidity, what we do have to do is start the patient on antiplatelet therapy. And important thing is smoking cessation. There is a very famous dictum in vascular society is stop smoking and start walking. So that is the famous dictum there. So all these patients who have PAD have to stop smoking. And also the goal is to reach LDL level less than 70. So you start them with antiplatelet and also hypolipidemic agents. And concomitantly, the diabetes have to be kept under control. And when we talk about this smoking cessation, even nicotine replacement therapy should not be advised. So when we talk about smoking cessation, it should be like we should give them bupropion or varnicillin, those drugs which will make them avoid smoking, but never to use a nicotine replacement therapy, because that also has some amount of nicotine this thing, so that will not completely help in decreasing the morbidity. Now coming to the how do we improve the peripheral extremity symptoms? Again, you need to stop smoking, and then a supervised exercise program. There is something called Burgess exercises. So where these patients are taught about how they have to move their limbs. So basically they have to elevate the limb and then do a cycling kind of movement, and then they have to keep dorsiflexing, plantarflexing their foot. So there are certain exercises which will be done by the physiotherapist. And also another important thing that we need to talk about is this drugs, stillos and pentoxifillin. So stillos, what it does, like the silestazole, it helps in vasodilatation, whereas pentoxifillin, what it does is it remodels the RBCs. So what happens is, suppose there is a occlusion here, and the RBCs have to travel. Instead of RBC being circular, the pentoxifillin kinds of makes the architecture of the RBC deform it a little bit so that it can pass through. So pentoxifillin is something that is commonly used in the clinical practice along with stillos. And the gold standard treatments are the surgical as well as interventional procedures, which we'll talk in detail. Now, talking about arterial revascularization, so there are three clear indications for revascularization procedure. That is your ischemic rest pain, ischemic ulcers, and gangrene. You may ask me why for a gangrene are we doing a revascularization procedure? Because whatever part is gone, gone, but we need to prevent the gangrene further, expanding proximally. So that's why we need to do a revascularization. And also claudication that interferes with the patient's lifestyle, severe claudication that he's not able to carry out any of his daily activities. So when we talk about angioplasty, so first it was started in 1964 by Daughter and Judkins. So what we do initially, what happens is they introduced a inelastic balloon which can dilate the particular blood vessel to a predetermined diameter and cause the vessel to dilate. So what happens is once you introduce the balloon will cause a shearing force. Suppose you have the plaque here and the balloon will cause a shearing force. It will crack the intima from the media, and what happens is it will cause stretching of the intima, and adventitia. So once this forms, what happens is like the same blood vessel, the plaque will become completely like there will be a little bit of space that is there between the plaque and the lumen. So basically, it is giving you a more space for the blood to pass through. So that is one thing. And also, after causing this remodeling, we are technically not removing the plaque. The plaque is just compressed and shifted, creating a lumen which is a little bit bigger. That is the mechanism of this balloon dilatation. And what is the advantage of this transluminal angioplasty is that it has lower morbidity, a shorter hospital stay, then also early recovery, and it is less morbid compared to an open procedure. You don't have to have a long incision. It's all through a small incision. And what happens is because of this lot of advances in this angioplasty, there are most of the iliac diseases are being treated uh, by angioplasties. Now, what happens is we will talk about some disadvantages of this angioplasty. What happens is once you do an angioplasty, like you do an endovascular balloon or you put a stent, what can happen is there will be need for reintervention. These patients, again, there can be stenosis, and again, they would have to go for another endovascular procedure. And some of them, what happens is there will be elastic recoil of this particular vessel. And also there can be intimal hyperplasia and there can be residual stenosis. These are the limitations. So to prevent all these things, we need to put something called a vascular stent. So along with balloon dilatation, what we put is a stent through this angioplasty technique. Now, when we talk about stent, what are the indication? Where do we have to put a stent? Suppose even after dilating, there is a residual stenosis of more than 30%. Then if there is an extensive dissection or there is a recurrent stenosis or if there is a chronic total occlusion, you need to put in a stent. Now, when you talk about stents, you need to know about the types of stents. So when we talk about types of stents, there are some balloon expandable stents, then self-expanding stents like nitinol, and there are some bioabsorbable stent as well, and drug-eluting stent. These drug-eluting stent, one of the recent advantages that these drugs are nothing but your immunosuppressant, like paclitaxel, then everolimus, all these things. So what happens is they prevent the intimal hyperplasia and thus the restenosis will be less. So these are in a nutshell about the stents. Now, if you ask me about the indication, we talked about stent is like a residual stenosis, but where else can we use this stents? Even in case of aortic aneurysm, you can do a stenting procedure. And there is something called endoprosthesis. So what is this? Is endoprosthesis is nothing but a stent plus a graft. So what happens is, can you see this stent here? This stent, along with that, there will be a coating of a graft, which is a PTFE graft. So these things are also used. These are like stent which are superimposed with the graft, and they are made up of this polyester thing. And these are very well useful in case of an AV fistula, aneurysm, and also in case of a long segment occlusion. Suppose you have an entire popliteal and tibial vessel blockage. So these kind of stent with the graft, that is called endoprosthesis, these can be used in case of a long segment occlusion. And what we do is we kind of compress them and put them into a small delivery system, and then that will go and fit exactly into the lumen. Now, coming to the complications of this stenting is that you have a puncture site complication. You can have bleeding and also false aneurysm, and also plasticite complication like thrombosis. This thrombosis is very important. We'll come to it later. And then infection can be there, and systemic complication can also be there. Like patient can have a sudden MI or CBA or renal failure. These things can happen. And there can be some distal vessel complications like dissection and embolism. So this is in short about the angioplasty. So you guys have any doubt regarding this? You can ask me.
Ma'am, regarding this stent with the
Graft.
actually graft, so
Yeah.
will it incorporate into the vessel or will it just
Wait,
stay
let
as?
me just add on that. See, as the name suggests, it's called as a stent graft. Okay. So the negative of a stent is that it's only metal, it's porous because you can't put in a complete steel tube inside. It is a laser cut structure. It has to be flexible and pliable to be delivered inside and to get attached to the wall. So that, but it is mechanically powerful. A graft on the other side is a non-porous structure, but doesn't have the power of a metal. So when you combine the advantages of strength of the metal with the non-porosity of a graft, you get a stent graft. So the stent graft, like Dr. Nithya said, you have specific indications to put it. Incorporated in the sense it doesn't get absorbed, but the inner layer of the device gets something called as a neo-intimal layer. So neo-endothelium kind of thing forms.
Okay, sir.
And the graft coating can either be Dacron or PTFE. It depends on the company or the indication which you use. It's not only PTFE. Most of the aneurysm cases, it's a Dacron. Non-aneurysm cases for the peripheral vasculature, like SFA for AV fistula kind of thing, would be PTFE.
Hello, sir. Sir, in a patient of this vascular compromise and having gangrene, can we do in a single sitting both gangrene excision and stunting, sir?
No, see, it depends on what type of gangrene is got. If
Okay.
it is dry gangrene, the
Yes, sir.
treatment process is 2 steps. If it is wet gangrene or infection, the treatment process is 3 steps. So in dry gangrene, you don't have any hurry to knock off the dead tissue because
sir.
even if you knock it off, it's not going to heal. Is it going to give you trouble now by just leaving it like that? No, it's not going to give you trouble. So improve the blood flow first, whether it is angioplasty or bypass, any method. You improve the blood flow, and that will itself will show you which is the proper line of demarcation. Give it some time, and then you have to go and amputate the toe, something like that, for dry gangrene. For wet gangrene, the first step, because the patient has an underlying infection, we may have to do a debridement or an additional toe amputation just to reduce the sepsis, the local sepsis and systemic sepsis. We are not doing that to heal the wound. You cannot expect wound healing just by doing the debridement and toe amputation. So once the local infection reduces, systemic sepsis reduces, the patient is more fit to do the next step, which is the revascularization by bypass or angioplasty. And now once you improve the blood flow, again you in third step you revisit the wound, may or may not require another step of debridement plus minus more toe amputations. That's a simple way to put it.
Yes, sir. Thank you.
I'll continue, sir.
Yeah.
So now we will talk about a surgical intervention. So surgical intervention, in short, you have a couple of procedures which are very important, like the end arterectomy, then bypass. Then for completion's sake, there are things like lumbar sympathectomy and omentoplasty, and there are other procedures also. But we will talk in detail about the bypass and the endarterectomy. So when we talk about endarterectomy, what happens is we remove the intima. So suppose this is your blood vessel. So there is a plaque, atherosclerotic plaque or something here. So what we do is we make a arteriotomy. First we will incise and then we remove the intima and half of the media, which includes your internal elastic lamina. So your media will have internal elastic lamina, then the small amount of smooth muscle fiber, then your external elastic lamina. So we kind of remove this internal elastic lamina and a part of the media, and we leave only the external elastic lamina there. And then what we put a patch, like we put a PTFE patch or something, So that what happens is your lumen is kind of increased. And whatever inside plaque is there, we need to remove this. So this is what in short about endarterectomy. You're going to incise, take out the plaque, remove a part of the intima, and also the part, remove the full intima, part of the media, which does not include the external elastic lamina, which you're going to retain it there. Then you're going to repair it with a patch, whether a PTFE patch or something. So this is endarterectomy. Another thing important is bypass. So bypass, if you have to talk about, say, suppose this is the aorta, abdominal aorta, common iliac, then you have the external iliac and then the internal iliac on both sides. Then once this cross the inguinal ligament, you have the femoral, then popliteal, then tibial and common peroneal. So what happens is, suppose you have a block in the aortic, abdominal aorta somewhere. So what you're going to do is, you're going to connect like this, aorto-iliac bypass. Suppose you have a block in the bifurcation. You're going to put in a shunt, that is aorto by iliac or aorto by femoral bypass. Similarly, wherever is the occlusion, from the proximal to the distal segment, we are going to put in a graft. That is the bypass in a crude way, if I have to tell you. Now, after understanding this much, we will talk about the graft that we use for bypass. So when we talk about, so something we need, right, to in order to anastomose this part to this part. So you have a graft, which is like your, you can even, there are very, so many types of graft. So when we talk about graft per se, you will have an allograft and a xenograft. Xenograft, as you know, it is from the foreign, like not from our species, it's from bovine or canine species. So the preferred one is the allograft. Out of allograft, venous allograft is most preferred. If not, then arterial homograft, like your radial artery or very rarely internal iliac also can be used. Then there can be umbilical vein graft. These are the type of graft that we use. And when you talk about the materials used for the graft, you have textile graft, that is your Dacron. Dacron is one of the textile graft, and another one is your PTFE. So these days, what they do is they kind of coat these Dacron with heparin, with antibiotic. There are a lot of advances when you talk about these kind of graft. They make it even biodegradable. What they do is, sometimes they first put in a small graft, like the scaffolding. They develop a scaffolding and they put a fibrocollagen. There is a fibrocollagenous growth over that particular material, and then this scaffold itself will form a graft, which is then harvested and it can be used as a graft separately. So there are a lot of things like endothelial seeding technique is also there, where they kind of take the endothelial cells and they are seeding into the graft so that the intima will start growing faster. So these are the types of graft. And when we talk about a ideal prosthetic graft, there are certain things that it needs to satisfy, like it should be biocompatible, durable, easy to sterilize, resistant to infection, non-thrombogenic, low cost, impervious, and ideal is never there. So these are the characteristics of a graft that you need to know. Now talking about bypass per se. So what you know as like
Dr.
anatomy.
Nithya,
Yes,
let me
sir.
just add something on the graphs.
Yes, sir.
So, what is the chemical name of Dacron?
Clinical name of Dacron.
Chemical name of Dacron. Dacron is actually the commercial name which has stuck over many decades. But
Okay, sir.
like how you said the PTFE,
Yes, sir.
which is polytetrafluoroethylene, what
Yes,
is
sir.
the full form of Dacron?
I'm not sure, sir.
It is
Ethylene
polyethylene
glycol.
polyethylene terephthalate. Okay,
PET.
so
Okay.
PET.
PET. Okay.
Polyethyl
Okay.
terephthalate is Dacron.
Okay, sir.
PTFE is polytetrafluoroethylene.
Okay, sir.
So the second thing is, where do you prefer using a synthetic graft like Dacron PTFE, and where do you prefer using a native graft like the grades of Iniswell?
Yes, sir. So synthetic graft is basically for a larger vessels. Like if we have to do a aorta iliac bypass, then we prefer a synthetic graft like Dacron. Suppose we have to do a fempop, like a femoral popliteal, there also you can put a PTFE. But if you have to go for a tibial, like infracrural vessels, then we use something called reversed saphenous vein graft, or even you can have an in situ.
No, we are not going into that at all.
Yes,
So
sir.
we're not going into reverse and all that.
Yes, sir.
Simple thing, vein or synthetic. First, we'll do that.
Yes, sir.
Okay. So, like you said, for an iota iliac segment, you cannot use a vein. You have to use a synthetic graft, either a
Yes, sir.
dacron or a PTFE. Both are okay.
Yes, sir.
Okay. For a femoral-popliteal segment, now this comes. You have three parts of the popliteal artery: above knee, at knee, and below knee.
Okay, sir.
Okay. So for above knee, it is fair enough to use a synthetic graft. Still,
Okay, sir.
great saphenous vein graft is far more better than a synthetic graft, even for
Okay,
a
sir.
bony. If the patient has a healthy great saphenous vein, preferable is vein over a synthetic graft
Okay,
for
sir.
a bony segment. For a
Okay,
below
sir.
knee segment, that's where everything changes. So when you have a distal bypass target, if it is the below knee popliteal artery or the tibial arteries, the preferred is a vein bypass.
Yes, sir.
There is very clear data showing the patency of the graft will significantly cross down once the graft crosses the knee.
Okay.
Okay. So
Yes, sir.
anytime preferable is vein over a graft. Now the reverse thing what you mean is the veins have valves.
Yes, sir.
So the natural flow is from the foot towards the heart.
Hmm.
So if you take out a vein and fix it in the same configuration, like the
Yes,
lower
sir.
part of the vein to the tibial artery and the upper part of the vein to the femoral artery, for example. If the valves are still patent, then the blood will not flow through because the valve allows only unidirectional flow.
Yes, sir.
It is designed to flow naturally from foot to upwards. So that's
Yes,
why
sir.
you can reverse the vein so that the valves allow the flow from up to down.
Okay.
Okay. But in reversed vein configuration, problem is size mismatch is very high. The upper part of the vein near the junction, I'm sure you guys would have seen open varicose vein surgery. The upper part of the vein is very bigger in size. The lower part of the vein near the leg or ankle region is smaller in size. So you're trying to do an anastomosis between a small size vein to a big size femoral artery and a big size vein to a small size tibial artery. So
Yes.
there is a size mismatch in a reversed
Yes.
vein. So then came the method of non-reversed vein, where you can use something called as a valvulotome, where you introduce the valvulotome inside the vein and break the valves manually. So once these valves are destroyed, you can use in a same non-reversed fashion,
Yes, sir.
so that the flow, you're not changing the position of the veins, but you're just destroying the valve so that the flow goes from up to down. So in the valvulotome also, there are two types. One is the Mills valvulotome and the Lemaitre valvulotome. Up to this level, at least you should know.
Yes, sir.
Okay. Yeah.
Yes. I'll continue. Same thing.
Just
When
a
we
minute, Shravan. Now,
Yes, sir.
currently, what is the proportion of peripheral vascular disease that you deal with stenting and angioplasty, and what proportion do you have to operate? That is to use bypass.
Uh,
60
sir,
40, 70 30,
in 70-30 easily, sir. 70
yeah,
endovascular, 30 open, sir.
30 open, yeah.
Yes, sir. Yes, sir.
So I think that is a significant change. And what we have to understand
Yes,
is
sir.
we have to compliment the vascular surgeons for keeping hold of the specialty for themselves, not letting interventional radiologists run away with it. So all the stenting and grafting are done by the vascular surgeons, unlike our gastroenterologic procedures, which are being done by the gastroenterologists. Okay,
Yes.
carry
Yes, sir.
on.
That's why we call our specialty a hybrid specialty, sir,
Yeah,
because we're able to give the best of both worlds for the patient. So there have been cases where the iliac component we would have done a stenting and the femoral component we would have done a bypass. So looking into the patient condition, the anatomy of the occlusion, we can give tailored approach to the patient. So that's the advantage we have there.
yeah.
I'll continue, sir. So, like we
What,
talked about
Nithya, what, let us say if there is no, if for example, the patient has had coronary artery bypass graft and they have used the saphenous vein, but he has
yes,
peripheral vascular disease, what do you do?
sir, we can even take cephalic vein also, sir, like for
You can use upper limb veins,
There is
but they are
stenting before.
not,
Yes.
that they are not long enough. So what they do, again, it is a difficult thing, and I think as Shravan mentioned, the moment you are going below knee, I think the occlusion rates are higher. What they do is do a PTFE graft, but then they use the saphenous vein or whatever vein there is to create a boot at the distal end so that the graft is then placed onto that boot. It used to be
yes,
called wolf boot or something.
Saint
King's
Mary's
boot.
boot, sir. Saint Mary's boot or Miller's cuff.
And cuff, you use a cuff and basically you create the cuff using the vein and then you anastomose the PTFE onto that. It is supposed to prevent the occlusion to some extent, but the
Yes.
fact is that because it's a below knee graft, the occlusion rates are higher anyway.
Yes, sir. Uh, uh, so continuing with the graft, so we talked about the reversed vein graft and also the where we don't reverse it. That is also called as a in situ bypass. Like where we don't take the here we don't harvest the saphenous vein outside. We just connect the saphenous vein. The proximal one to the proximal part of the artery and the distal one to the distal part of the artery, and then with
So
the
they use, there is a small, I think the angioscope, so they use the angioscope to go down the vein and
yes, sir.
destroy the valves and then use it in situ, so
Yes, sir.
non reversed graft.
Yes, sir. So yeah, like the valvulotome is usually passed to the side branches of the saphenous vein through, like how sir said, through an angioscope. And then the couple of valvulotome is Lemaitr's valvulotome, Mills and Hall's valvulotome. And like sir said, what is Saint Mary's boot or recently it is, I mean, it's also called as Miller's cuff. Like what happens is, suppose we have the artery here and when we don't have enough length of saphenous veins, we take a PTFE graft. The graft at the distal end, we put this vein patch. So the vein patch will come at the distal end. That will kind of prevent occlusion. So this particular vein patch is called as Saint Mary's boot or Miller's cuff. And now talking about this bypass, there is something called anatomic and extra anatomic bypass procedures. So anatomic is when it goes according to the level of occlusion. Suppose, say for example, like how I told you before, if there is an aortic occlusion, you bypass it from the proximal to the distal segment. Extra anatomic is when, suppose, there is some kind of a problem in the abdomen, like where you can't go into the abdomen, or if there is some other issues, then you need to take the graft from other sides. So in extra anatomic, you have a femoral bypass, or you can even have a axillo femoral bypass. So these are like very rare things. Usually done only in settings where it is very difficult to approach the immediate proximal segment.
No, I
Now,
think it's mainly for infections, ma. When there is graft infection,
yes, sir.
for example, patients have previously had a graft put in, and when there is graft infection, you can't do anything. You have to, take out the graft and proximally ligate the vessel. So then, because it is already infected, you can't actually use because then it will get infected again. So what you do is you do a axillobifemoral or femoral, and usually if it is aortic, then you will have to do an axillofemoral graft.
Yes, sir.
So
So,
the commonest setting is not because you can't approach it,
yes, sir.
because there is infection. The graft is infected and you can't actually do anything there. So you will have to take out the infected graft and then ligate the vessel, and then you have to bypass using the axilla, from axilla down to the both femoral arteries.
Yes, sir. So that is in short about bypass. Now, just the complication of bypass procedure, like it is similar to any other surgeries. Like you can have a thrombosis, then you can have aneurysm, then there can be bleeding, then there can be
More
like grafting.
wait, more pertinent question would be,
Yes, sir.
if you do a femoropopliteal bypass with a
Yes, sir.
saphenous vein, what is the patency rates? And if you do it with the PTFE graft, what is the patency rate or Dacron graft?
So around
So,
80% at 5 years, sir, with vein, and with PTF it is around 20 or 30%.
No, I don't think it's that low. Shravan, I think the 80% is probably correct. The occlusion, the patency rates range from 65 to 80% for the vein, and about 40 to 60% for PTFE or Dacron graft.
Yes, sir, that's right, sir.
Yeah.
yes, sir. And also, recently, the results of both interventional vascular procedure and open bypass for an iliac disease is almost the same. So technically, most of these bypass grafting procedures have been taken over by the endovascular techniques these days. And when we talk about this edema, hemorrhage, like the complications of bypass,
Just a minute, ma.
yes, sir.
Shravan,
Yes, sir.
so we said it is 70-30. What is the
Hmm.
absolute indication to straight away doing a bypass surgery rather than using endovascular?
Sir, like we said, the task deletion, sir, you have a long segment occlusion,
Ah,
and if the patient is fit enough to undergo anesthesia, I would any day prefer doing a bypass rather than endovascular, sir.
okay. I think that's the answer.
And in exam also, sir, most examiners prefer telling open surgery rather than directly commenting on
Yes.
endovascular, sir.
Yeah, endovascular. What is the reason why generally it is believed, I don't know whether it is still believed, the
Yes,
profunda femoris is generally resistant to occlusion. What is the reason for that?
sir, we consider it as a lifeline for us, sir, because even when you have a occluded femoral artery, the
Yeah,
profunda has so much branches, especially muscular branches, is significantly higher than the SFA, sir.
yeah.
So that's why the profunda survives, and most of the time, the collaterals from the profunda is what reforms the different distal segments, sir.
Correct. So that is why they sometimes do a profundoplasty,
Yes, sir.
so
Yes, sir.
augmenting the inflow to
Outflow.
the, yeah,
Yes, sir. Yes, sir. So especially if the atherosclerotic plaque is extending into the profunda, sir,
yeah,
we prefer to open up the profunda also and clear the plaquey
clear,
material there.
correct. Yeah.
I'll continue, sir.
Yeah.
So when we talk about the complication, there is something called ischemia reperfusion, which is a very common thing that we read in pathology. So next day, once this reperfusion happens, there is a very high chance that these patients can develop compartment syndrome. So the
Now,
post-op,
Nithya,
sir?
you will have to qualify this very carefully.
Yes, sir.
Ischemic reperfusion is much more common in acute ischemic events as
Yes, sir.
opposed to chronic ischemic events.
It's very true, sir. Very true.
Yes,
I was
sir.
just about to tell that, sir. You added it in.
Yes, sir. So here it is about because in a chronic there will be always collateral that is already formed there, but in an acute setting we need to keep in mind about compartment syndrome. So that is one thing to keep in mind, and to as a final closing thing, we'll talk
No,
about.
no, no, not just compartment syndrome. I
Yes, sir.
think there will be washing up of the toxic metabolites that
Yes,
are
sir.
accumulated in the ischemic limb. And many
Mm.
times there is also rhabdomyolysis and acute renal injury. So all
Yes,
of
sir.
these things have to be, it's not just about compartment syndrome. That is also important. But
Yes, sir.
reperfusion injury is a combination of many of these things. Shravan? Hello, Shravan is not, is he on call or something?
Yes, sir. Sir, it's very true, sir. More important is due to the anaerobic metabolism,
Yeah,
there's too much lactates, potassium, and other oxidative factors,
correct,
inflammatory factors which build up. And on the process of treating the patient, all this gets spread to the systemic circulation, and that has systemic effects like arrhythmia, renal failure, and all that,
correct. The
and
other thing is
pulmonary edema.
some elements, see, when there is ischemia, there will be some element of muscle injury, and that rhabdomyolysis that has happened,
Yes,
and
sir.
the components of that will cause acute renal failure. So you have to watch
Yes, sir.
that, perfuse the kidney well, and dilute the effect of rhabdomyolysis.
Yes, sir.
Carry on, Manitya. See, I think this is how you have to talk. You have to talk
Yes.
about, the students should go away with the impression that this reperfusion injury is much more common in acute ischemia than chronic ischemia. And what are the components of reperfusion injury? One is compartment syndrome, of course, no doubt about that. So how do you deal with compartment syndrome is generally how you deal with it in any way. So that is one. And the other thing, as Shravan said, the toxic metabolites, potassium, and all these things, and the components of muscle, breakdown, all of these have to be addressed.
Yes, sir.
Okay, carry on.
So finally, a couple of points about lumbar sympathectomy. So what we do is here, the uh, L1, L2, these nerve roots. What we do is we kind of cut them at one side. We disconnect the L1 and L2. On the other side, we disconnect the L2 segment. These are quite obsolete procedures, but why we do is to improve the cutaneous flow. So one thing that we need to know that this lumbar sympathectomy should not be done in a patient who has claudication, because the muscle is not getting enough blood supply. So when we kind of shunt the blood supply from the muscle to the skin, the claudication pain will worsen. So this is one obsolete procedure that is, I mean, I think rarely done these days. And also obentoplasty, where we bring down the momentum from the abdomen and then we put it into the uh, leg. That is also like it's all outdated procedures. That is just for completion sake.
No,
And
no, no. I think you should probably, I think Shravan will agree. Yeah, I don't think you should mention these procedures at all anymore.
yes, sir.
Because I think the only indication for sympathectomy is cervical sympathectomy for hyperhidrosis.
Yes, sir.
And I don't know whether it is useful for Raynaud's Shravan. Are they?
Sir, very rarely, sir, very
That's
rarely.
what they are
And that
not
too,
useful.
if at all we have to do, now we have moved to chemical sympathectomy, sir. For
Uh,
cutaneous, you can inject absolute alcohol in the same area where in the L1, L2 segment, that will burn off the veins and give the same effect as a manual removal of the nerve plexus there.
yeah. I think sympathectomies are given up, so I don't think you need to
Yes,
mention.
yes,
I
sir.
don't know. Hopefully, no examiner will ask about it.
Yes, sir.
Yes, sir.
And finally, when the patient is in full-blown gangrene, amputation is the final choice that we have to lessen the infection. I think Praveen has dealt with amputation earlier. So thank you, sir.
I would just like to add a couple of things. So
Yes,
let's
sir.
say you have a patient coming with claudication pain. So what would be your line of management?
Sir, first I would clinically examine the patient.
Hmm.
I would look for the distal pulses and
Hmm.
also ask history. Like, first of all, I should rule out what sort of a claudication pain, whether it is neurogenic, osteogenic,
Yeah.
or
No, it is vascular. I'll tell you, it is vascular claudication. And
yes,
let
sir.
me add, patient has a well palpable femoral artery, but
Yes, sir.
popliteal artery and the ATA, PTA, TPA are not palpable. And the, let's say the Doppler also confirms a chronic occlusion of a segment of the SFA with some Tibian disease.
Okay, sir.
What is your management?
SFA and tibial disease. So since the Doppler says this, first I would ask for an MR angiography, and side by side I will ask the patient for history wise whether he's a smoker, and also I will start him on stilastosol and pentoxifylline, and also
Sir,
antiplatelet.
Nithya, you
Yes,
need to define. See, the thing is, you yourself said about whether the claudication is affecting his lifestyle or not.
Yes,
So
correct.
that is the first question you have to address. See,
yes,
if
sir.
it is a 80-year-old who is having claudication, you are less inclined to doing any interventional procedure. If he is a
Yes,
40-year-old, you are more likely to do something interventional. So
yes,
you first define what is the what is the claudication distance. Then you define what is the lifestyle of the patient and how much is it affecting his lifestyle. Then you have to look at all the smoking, diabetes and all that, and BMT, best medical treatment,
Yes.
most of the time. And then if because you have to reserve your interventions for patients who have, as you said, ischemia, resting pain, and resting pain with tissue loss, and threatened gangrene and things like that, where you're more likely to succeed as
yes,
opposed
sir.
to with claudication, because you are adding a complication which may threaten the limb. So you have to use your judgment to ensure that it is only done in patients whose claudication is significant and affecting their lifestyle, and also the age of the patient and other comorbidities. And first thing you have to do is to supervise exercise program, best medical treatments, cessation of smoking, and ask them to teach them to walk through the pain, pain the threshold,
Yes,
because the
sir.
more you walk, the claudication distance will increase. And the what happens is, if they were stopping at 200 meters, they will then stop at 250, 300, 400, and so on. So they have to walk through the pain barrier, which will improve the neovascularization and formation of collaterals. So that should be the approach, rather than straight away saying I will do MR angiography and all these things. You have to
Yes, sir.
reserve these things in as you said yourself, in the specific indications where you are considering intervention. Shravan, am I right, or is there
Yes,
anything
sir.
else?
Absolutely right, sir. Absolutely right. For claudication, especially for the femoropopliteal and tibial segment, 95 to 97% of the patients improve without any procedure. So, like sir said, best medical therapy, correcting all the comorbidities, smoking cessation, plus exercise program. This itself will completely get rid of the symptoms.
Yes, sir.
So, one thing I would like to add, does the same method, uh, is it true for the iotoiliac segment?
No, sir. Iota iliac segment, we need to.
Yeah, iotoiliac segment, they respond very poorly to medical management. You can always give a trial. You can always give a trial, but they respond very poorly. Only maximum 20%, 15 to 20% respond to medical therapy. So iotoiliac segment, it is, they would come with life limiting claudication, and you can give a short trial, but for them it is ideal to go and intervene directly. So comment on CTs and MRs only if you are planning to do something. Otherwise, don't
Okay.
comment on that at all.
Vinod,
Okay, sir.
Vinod, why do you think the iliac segment responds better to intervention?
Sir?
Anybody for that matter, Vinod, Nikita, Praveen, even Ainas, Samir. Nobody? See, I think usually it can be different, of course, but usually the iliac segments, the narrowing, short segment narrowing, and the pressure head of the inflow is so high that the moment you open up the vessel, you will find significant improvement, as opposed to SFA and things where some it can be one short narrow segment occlusion, but by and large it will be much more of a longer segment disease. So I think uh, iliac responds better because it's a short segment disease with a high pressure inflow. So the moment you open it up, it will improve the symptoms dramatically. Shravan, anything to add, or is it
No,
wrong?
sir. No, sir. That's perfectly right, sir. Perfectly right.
So, any more questions, students?
Just like to ask one last thing.
Yes, sir.
Dr. Nithya,
Yes, sir.
patient has come with you with the gangrene of the right side. You've done all
Okay.
the treatment, flows improved, infection is down, wound is responding.
Yes, sir.
But your imaging is showing left side is also having a lot of blockages, sometimes even more than the index side. But the patient is asymptomatic. What would you do?
Sir, we should wait and watch only, sir. Like till the patient becomes symptomatic, it's better not to.
Exactly. So basically, the index side is in critical ischemia. The non-index side is in claudication. So you treat it as claudication.
Yes.
Okay. So just because the angiogram is showing some blockages, there is no rule that you have to go and correct it.
Okay.
If that is the thing, the patients with peripheral arterial disease, if you scan any part of the body, you will pick up at least 20 blockages everywhere.
Mm-hmm.
So that
So
actually the adage treat the patient, not the X-ray, holds very good here.
yes, true, sir.
So if are there any questions? Samia, what is your assessment of the class?
Very nice class, sir. Very good discussion. A lot of aspects were covered. Not also most important points for exam were also covered. Very nice class.
Nikita, student point
The
of view.
the flow of the class was very good, sir.
Uh,
That was the most important point I felt, sir.
Shravan, your assessment of the class?
Sir, it was quite good, very engaging. Compared to the previous class, I think Dr. Nithya has taken up your pointers on how to keep it more crisp and relevant. So it was a good job well done, sir.
Thank you. From my point, I have to agree with what Shravan said. I think Nithya, you have a very good potential to be an extremely good teacher because you have elaborated on the important points at the right time, and you have learned very quickly as to what is important and how to deliver it. So it's good, very good, class. And I think that is why the more you do it, you'll get better at it. And I think the content was extremely good and very relevant. And I have to place on record Dr. Shravan's involvement. I think he interjected at very right, appropriate moments and gave us a lot of good wisdom. So I think all in all, I think peripheral vascular disease has been well covered, and I think it is a what shall we say, blueprint as to how you should attempt to approach the peripheral vascular disease. Thank you very much and good night.
Thank you, sir.
Thank you, sir. Good night, everybody.
Good night.